again, thank you for joining the Superior Health Quality Alliance Roundtable conversation. My name's Kim Heft, and I am joined by my colleagues, Jerry Hineker, Jill Hansen, and Kelsey Ostergren. Welcome back to those that have been joining these weekly calls. If you're new to the call, we are so glad that you made it here to your first COVID-19 roundtable session. Now, we host this session each week. It's a 30-minute educational session where we highlight important topics related to COVID-19 vaccinations, boosters, and other nursing home related topics. We hope you're going to be able to join us each week. And one thing though, I would really ask of you is that if you have anything that you'd like to learn more about or that you're struggling to figure out, send us a message. Tell us what you think that topic should be, and maybe we could add that for a future session. There will be a survey at the end of this session, which we would like you to fill out. Please provide us with some feedback on how you thought the session went. And Jerry will be putting the link for the PowerPoint presentation in chat momentarily. And in case you missed it and came in later, don't worry, we'll put it in there again. Please use that chat box to share any comments, questions, anything that pops into your mind during the presentation, and then we'll use that for discussion in our Q&A session. Now, before we get started, though, I'd like to share an update that we just got a hold of yesterday from the CDC regarding COVID vaccination cards. So that little white card, that vaccination record card that you get, after you've received your COVID vaccination, they're getting full, right? Especially for those that are over 50 years of age or they're immunocompromised individuals. And so there's no more room on the card. So what CDC recommends is that basically that a second card should be completed. And you take the two cards and you staple them together. Please encourage your patients, or I should say your staff, to photograph both cards in case they become separated. And if you need to use your card, maybe it's required for travel or employment or what have you, you're going to need both cards. So again, good to take a picture, good to staple them together. So let's see here. I would say that is the update on vaccination cards. And with that said, I'm going to turn the floor over to Kelsey.
Awesome. Thanks, Kim, and good afternoon, everyone. So today we're going to spend some time talking about the BA.5 variant. And I know that this is something that has been circulating in the news and in the media. And so I just felt like this might be a good opportunity to kind of dig into it a little bit more and talk about kind of what it is, what we're seeing, and just spend some time having discussion about this. So just some of our objectives for the session today, again, just talking about BA.5, both the illness, severity, what we're seeing with hospitalizations, how it differs from some of our previous variants, and then talking through vaccination and treatment efficacy, as well as some upcoming treatments and vaccines that are sort of on the horizon for this fall and still in development. All right, so let's start here. What is BA.5? So as you may know, BA.5 is our newest variant of concern, and it is part of the Omicron family. It's a subvariant of an Omicron, and it was actually first detected in South Africa in February of this year. And it didn't take long. By May, people were really starting to sort of ring the alarm bells about concerns over transmissibility. And in the US, we actually saw our first case here in April. So fast forward now to mid-July, we have 89 countries across the globe who have confirmed cases of BA.5. So really, within a span of 5 months, it's really taken off and has spread rapidly. So globally, it was responsible for about half of all infections in, kind of early mid to July. And we know that that number has only continued to climb since that point. Here in the United States, BA.5 was responsible for nearly 90% of the infections nationally for that last week of July. And so you see this graph on the right is data from the CDC COVID data tracker that I just plotted, which compares region 5, so that blue line, which is the Midwest, against the national data, which is shown in the orange. And what you can see is that the trends are very, very similar, almost identical between the two. So really shouldn't be a surprise that what we're seeing in this region is similar to sort of what our national trends are. But I think the other thing that's important to kind of point out as we're looking at this is just how quickly BA.5 has taken over. Right, so in early May, we didn't have any cases, and now fast forward 12 weeks later, and it's accounting for 90% of those infections. So really crazy how quickly this has taken off. But again, I think that why we felt that this was an important session to do and just to kind of revisit what this is and kind of what's going on here. So again, this is just another image from the CDC showing the rise of the BA.5 variant since early May. Which is sort of that teal color at the bottom, and then the decline in the BA.2 strains, which is that kind of like orangey color, and the pink that were our earlier Omicron variants that we had seen, kind of earlier in this year. I really like this. This CDC COVID data tracker, I would recommend you bookmark and just kind of take a peek at. It's fun if you love data and statistics and numbers. Otherwise, you can just keep coming back here every week and we'll do it for you. All right, so let's talk a little bit more about some of the characteristics of BA.5 and really what sets it apart from some of our earlier variants and previous Omicron strains. So this is an antigen map. I personally am a very visual person, so this for me was really helpful just to get a sense of how different or how similar these different strains are from one another. So I just want to call your attention to that sort of upper left-hand corner, which is going to be our Omicron cluster. So you'll see BA.1, 2, 3, all sort of the previous Omicron strains we saw this year, and then 4 and 5, which are very closely related and particularly of interest for this discussion, BA.5. And so this is going to be important to see sort of the distance of that group of Omicron strains compared to the Wuhan strain and our Alpha and Delta that are kind of down in the bottom right. And so, the way that I would sort of think about or encourage you to think about this is how your body would view these things, right? So if our body was looking at this map, the variants that are closer together or clustered, like we're seeing with that Omicron group in the upper left, those are going to look more alike to our immune system compared to those that are in the bottom right, so our Delta or our Alpha strains. And so this is going to play a key role in how our body is responding or not responding to these different strains. And we'll talk about that in some more detail, but hopefully this just sort of visual picture gives you a sense of really how different some of these strains are from one another. And then again, sort of that little Omicron family in that upper left-hand corner are fairly similar to one another. So why is BA.5 so different? I'm not going to get too in the weeds with this, but I do think it is just an important background to know how BA.5 is genetically different from our previous Omicron strains and frankly, our other COVID variants in general, just so that we can understand why it is doing the things that it is. One of the, I think, notable things that we've seen with BA.5 is that it has changes across its structure. And so our previous variants only had changes to the spike protein. And so I think, the thought sort of in the scientific community here is that because BA.5 has changes across the structure, that is really contributing to why BA.5 is behaving in the way that it is. So 3 notable changes that I'll call out here. The first is a change to the spike protein. And so this is really how the virus or our cells attach to the virus, which means that the virus can more easily attach to and infect people, which is a problem. The second is a mutation that enhances the virus's ability to downregulate proteins, enzymes, and other signals. And there's actually some early evidence coming out of Australia that shows that BA.5 is actually replicating more rapidly and more efficiently than previous Omicron subvariants, again, related to the way that it's sort of interacting with our immune system and the way that it's disrupting those signals that our immune system really needs to be effective. The last mutation here that I'll just briefly touch on is a mutation in the viral membrane that sort of helps the virus suppress our immune system and again, sort of enabling that cell invasion. So circling back to point number one here and some of the changes that we're seeing in the spike protein that's leading to increased infectivity, I want to talk a little bit more about transmissibility because I feel like we keep touching on this and talking about it, but it is really important. So when we talk about transmissibility in epidemiology, you may commonly see this R0 or R0, which is used as an indicator of how many people could be infected by one sick person, right? So for really contagious diseases like our measles, one sick person could infect upwards of 18 other people. For flu, this is somewhere less than 1 to just over 2. So it does vary, depending on the disease, and there is a little bit of a range there. But a lot of these are not values for all these different diseases have been very well studied, and there are these scientifically agreed upon values for these diseases, which I've listed here on the slide. I think where sort of this caveat comes in and why some of these things are highlighted is because we don't really know what this is for COVID yet. And I think part of the reason that we don't have this number is that the virus is constantly changing, and we are seeing differences in how transmissible the different strains are. So just to give some sort of ballpark, the CDC had published research in 2020 that showed that the R0 for COVID was somewhere between 4 and 9. And then there's other research coming out of the Imperial College of London that's estimating it between 1.5 and 3.5. So kind of in the same ballpark, but one is about double the other. So again, we've got some more research to do on this to really try to figure out what that number is. I think all of that to say, because we still don't have agreement from the scientific community about what this number is for COVID, even for some of those initial strains, you can imagine the discussions that are going on right now, and frankly, some outright disagreement about what this number is for BA.5 specifically. I have seen some people say it's upwards of 18.6, 19, which would make it more transmissible than measles. Other people have said absolutely not, that math is not correct. We think it's miscalculated. Moral of the story here is we don't really know. What we do know is that BA.5 is in fact more transmissible than our prior COVID strains due to some of those mutations that we talked about on the last slide. But again, we don't really know how much, or we don't have a way yet at this point to quantify really what that increase in transmissibility is. One of the things we are hearing quite a lot about right now is that BA.5 is being spread outside. From a scientific standpoint, we don't actually know if outdoor spread is truly happening at an increased rate. However, because the BA.5 variant just on the whole is more transmissible, we would expect to see an increase in both indoor spread as well as outdoor spread. So again, we don't really know. It's probably happening outside more than it was, but on the whole, again, it's just more transmissible. So of course, it's going to happen outside as well as inside. I did include a quote at the bottom here, which I really liked, from a professor at Virginia Tech who was talking about how, yes, these new variants are more transmissible, but the risk of transmission outdoors is still going to be lower than it is indoors, due to some of the things that we've been doing for the last 2+ years, right? Social distancing, the ventilation, etc. All right, so moving on from transmissibility to our incubation period, we are seeing a shorter incubation period for BA.5 compared to what we had seen previously. So once you've been exposed or infected, we're typically seeing symptom onset somewhere between 3 to 5 days, which is much shorter than that 7 to 10 day window we had been seeing previously. Moving into symptoms, the symptoms of BA.5 are similar to those of our previous Omicron subvariants, resembling the common cold here. I think it's important to just sort of call attention to the fact that we are seeing some slightly different or new symptoms, like muscle aches, back aches, neck aches, that kind of thing. And sort of a word of caution here, some of these symptoms, either alone or in combination, may mimic meningitis. So that stiff neck, severe headache, that sort of thing. So just something to be aware of as you're potentially seeing this in your facilities, in yourself, your families, et cetera. Just a note there. There is some anecdotal evidence of night sweats and insomnia with BA.5 as well. I've not put that up here, but just wanted to at least throw it out. So if that's something you're seeing, we're starting to hear more reports of that. The fever, loss of taste and smell, those are both becoming less common with BA.5. And they're saying that less than a third of COVID positive cases now are reporting fever. So what once was sort of like this hallmark sign of COVID really has started to dwindle as the virus has evolved and our bodies are reacting differently. With BA.5 as well, we are seeing more upper respiratory symptoms and less lung involvement, which sort of leads us into disease severity. So in terms of disease severity, we don't have evidence at this point to suggest that BA.5 causes a more severe disease. Because there is less lung involvement, as we just spoke about, some are hypothesizing that the disease from BA.5 may actually be less severe, but again, we don't know that definitively. What we have understood until the last couple of months is that BA.5, the risk of hospitalization was stable with what we had seen previously, but there was a new study out of Denmark that found that BA.5 did in fact increase risk of hospitalization. So I think on that, again, the jury is still out. We continue to look at, sift through and digest all of this new research, and we can just continue to keep an eye on what that latest information is there. All of that said, I think given the increase in transmissibility and the number of people that are getting infected, we are going to see, and frankly, we have been seeing an increase in hospitalization, even if the disease is less severe. So the graph on the left came from CDC. You can see sort of to the right side, there is a slight increase, certainly not anything like we saw in January with that Delta wave, but there has been a slight uptick there. The quote on the right is from a physician who's the director at the Scripps Research Institute, basically speculating something very similar to what we've seen, at least thus far in the CDC data, that our hospitalizations will not reach the same levels that we saw during our Omicron surge, but that we are going to see an increase. So again, there seems to be some alignment with the folks that are working in this field, what the data is showing us, which is good. Another graph from the CDC, again, showing this sort of same thing with the uptick in hospitalizations this year, but certainly less than what we've seen in previous surges. All right, so now that we've kind of talked about the current state of the BA.5 variant, I want to highlight some of the changes to our immune system's response to BA.5, since this is really going to be one of the hallmark characteristics of this strain and part of why it has spread so rapidly. So by way of a very quick recap of our immune response, so we develop antibodies through either our immunization or our natural infection. And these antibodies are able to attack or to neutralize the virus by sticking to those spike proteins or those antigens. And the spike proteins are really going to be important to our immune system because this is how our antibodies are able to tell the different pathogens apart, right? So since our since our antibodies are produced for a single type of antigen, that detection is really important. So you can almost think about this as like a lock and key, right? There's lots of locks and lots of keys in this world, but if you don't have the right key for the right lock, it doesn't matter how many keys I give you, you won't be able to get that lock open, right? So I made a little drawing here on the right. So our antibody, again, which is produced either through that natural infection or through immunity, and the shape of it, you can see would target antigen 2. By the shape of antigen 1, that antibody will not be effective, again, because that key doesn't really fit in there. So what we're seeing with BA.5 is that the changes to the spike protein are causing our antibodies to not be as effective, right? So with this viral mutation, you can see in the image from the left is the virus we started with to the one on the right, and that antigen 2 receptor has changed, right? So that changed, the antibodies have not changed. So now they're kind of struggling to fit together. And so since our antibodies really rely on those antigens to identify that target, if they change, our antibodies don't know what to do, right? So just to sort of like pull this out of scientific context and give you like a practical example. So we know it becomes really hard to identify something or recognize something if it changes every time we see it, right? So if somebody cuts all their hair off, dyes it a different color, loses a ton of weight, changes the way they dress, it might be hard to recognize them, right? So the same then is true in this context. So what we're seeing with BA.5. So the variant has effectively put on a disguise, if you will, and our body's having a harder time identifying it. So the virus is just sort of circulating, going unnoticed, and effectively evading our immune response. So even though we've been vaccinated or we've had COVID, or maybe both of those things are true, our antibodies are, running around trying to find the virus. But because the virus now sort of has this disguise, we don't know if that's what we're looking for or not, right? We're having trouble differentiating, is that the thing that I need to be targeting or not? So in general, from an evolutionary standpoint, we know that the more cycles of replication that a virus undergoes, and the more hosts it has, the chances for mutations and changes to the virus have increased. So all of that to say that the antibodies that we have are not as effective against BA.5. A couple of things I want to call out from some recent research. So the first is out of South Africa, which found that the antibodies we've developed are 3 to 4 times less effective against BA.5 than they were against some of our original Omicron strains. And so what this means is that because BA.1 and BA.2, those original Omicron strains, are different enough from BA.5, the protection that we had, that cross protection, is not as great. And thus, our body's not able to identify and eliminate that BA.5 variant. The second study is out of Qatar. And so this actually showed, and this is really interesting. So this showed that the vaccine-induced antibodies are actually more effective against BA.5 than the antibodies that we would produce from natural infection. So really what this is telling us is that the current vaccines offer broader immune protection compared to just infection alone, right? Because infection alone would only be one strain, and our vaccines sort of give us that broader coverage. So while we're on the vaccine front, let's talk a little bit more about our current vaccines and their protection against BA.5. So what we just saw is that vaccine antibodies are better than the natural infection antibodies. However, our current vaccines were made to target the spike proteins that were found in the original COVID strains. And since we know that virus has changed and mutated, and that spike protein is different, our current vaccines are not as effective as they were against prior strains. So that said, being up to date with a booster or with 2 boosters if you're over 50, it is still protective against severe disease and against death. There is this emerging research out of South Africa that vaccines actually provided great protection against hospitalization. So almost 90%, which is really good when we consider the fact that we're talking that this vaccine is less effective, and yet we're still seeing nearly 80% effectiveness at preventing hospitalization. So not as great, but it's still really, really solid. Moving into reinfection, so we are starting to see a lot more reinfections because, again, this current vaccine is not as effective against the strains that are currently circulating, namely this BA.5 variant. In the last 3 months since May, the rate of reinfection has actually doubled, which really shouldn't be a surprise, but I was kind of shocked when I saw that. So why is that? As time goes on and people get either further from their last vaccine or their last booster, right, their immunity is starting to decline. And so that sort of puts us at more risk, and our likelihood of being reinfected goes up. What we saw actually last month in July is that 1 in 3 COVID infections were actually reinfections. And so part of this is due to sort of that denominator, the total population at risk. And so when we think about this, of the total people who could be infected with COVID, a large number of them have already had COVID, right? So that means if they were to get infected, it would be a reinfection, not a brand new person who's never had COVID before. So a few other reasons just to sort of call attention to, certainly the emergence of BA.5 is one factor in talking about the transmissibility and how it's able to evade immune detection, I think is really important here. People in general are discontinuing mitigation measures like mask wearing, social distancing, and certainly just in general, the widespread ending of mitigation measures, mask mandates. I know airlines has been sort of a big one lately, but all of those things are kind of leading us to this culmination of a virus that's more transmissible. Potentially the disease is less severe. The symptoms are a little different, and we're dropping masks. We're maybe farther from vaccination. And this is just sort of this perfect storm of lots of new infections. So a few other points about reinfection I wanted to touch on. So there have been 3 different Omicron subvariants or Omicron strains since April. Because they have changed so quickly and so rapidly, that means that it is possible for somebody who got infected with a previous Omicron strain, so like maybe BA.2, to get reinfected several weeks later with a different strain like we're seeing now in BA.5, since we know that that cross protection or that immunity that we develop to one doesn't really 100% protect us against the other. We are also seeing that reinfection is occurring in as little as 28 days. So again, this is shortened significantly from the 90 days we had seen kind of at the beginning of COVID, and again, kind of culminating in this perfect storm of things to put us at risk. Another study out of Qatar looked at how well these antibodies protected us against BA.5, comparing an infection with a pre-Omicron variant to infection with an Omicron variant. And so what we see is that if you got infected with Omicron, it offers better protection at getting reinfected with Omicron. So 75% effectiveness. Versus if you were infected with, like, say, Delta, your protection against Omicron would be much less. And again, if you think back to that antigen map with all those dots in that cluster in the upper left corner, where our Omicron family was hanging out, those are different enough from our other strains, again, that our body is almost viewing them as 2 separate things, even though we know that they're not. It's just a mutation there. So I think both of these things together may help explain some of the reports that we're getting about people who have maybe recently recovered and then are being reinfected with COVID in that very short amount of time because they're not getting the same strain. All right, so moving into treatments and sort of what's next here. So currently there are 3 treatments which are effective against Omicron. Our first is Paxlovid, an oral antiviral, and this really seems to be our best treatment option right now. It should be given within 5 days of symptom onset and is taken twice a day for 5 days. I know there's been a lot of news coverage on this lately as our president, had COVID and got Paxlovid as a treatment. One sort of sidebar commentary I'll add here is that we are starting to hear about this Paxlovid rebound. And so what we understand is there's a small percent of patients who are treated with Paxlovid who test negative at day 5. So when their 5-day course of treatment is up, they're testing negative. But then a few days later, they actually go on to test positive again. So once that antiviral has been discontinued, they're now testing positive. And so some of the early sort of speculation here is that the treatment might be suppressing viral replication. And so then once the medicine is stopped, the virus continues on its way and just replicates like crazy, which is why a couple of days later, we're seeing that positive test pop back up. Again, this is still going to be our best treatment option. That sidebar commentary about that rebound is not in 100% of cases. It is just that sort of small percent of patients. We don't know what that percent is at this point, but just at least wanted to mention that if this is a treatment that you're using in your facilities, if you're seeing this, so you sort of have some framework of what's going on. Is this something that we would expect, or is this something totally crazy? Our next treatment option is remdesivir, another antiviral drug that does have good efficacy against Omicron. This is an IV treatment, 3 days. And there was a recent article published in the New England Journal of Medicine talking about patients who had received remdesivir, and they had overall 87% lower risk of hospitalization or death. So really, really strong evidence there. And then our last is Evusheld. Intended for this pre-exposure prophylaxis. There is data out of the University of Oxford that's showing that this is still effective against Omicron, even though it is perhaps less effective than it would have been against original strain, which really seems to be sort of the common theme, is everything is a little less effective against BA.5 than what it would have been previously. And lastly, in the group of things that are not effective treatments for Omicron would be our monoclonal antibodies. Since they are highly unlikely to be active against Omicron, they're obviously not recommended for treating it. And since nearly all of the infections we're seeing in the US at this point are Omicron, they've just kind of put this bucket of probably this isn't the best option to use and would not recommend. So sort of up and coming, what's next on the COVID front? First, which I'm sure you are all aware of, are these Omicron specific boosters. So in late June of this year, the FDA basically told our vaccine makers to update their booster formulations to add this Omicron component to target that BA.4, BA.5, family. So Pfizer and Moderna are both actively working on the development, testing, and deployment of these boosters, which is anticipated to be ready this fall. I think what we're hearing is like September timeframe. So more to come on that as this sort of unfolds. There is some hope, I think, in the scientific community that these new boosters will help not only bolster protection against the Omicron family, so what we're dealing with right now, but also other future variants, right? So what we had seen with our initial vaccine is that it was targeted for one very specific virus. Now that we've watched how this virus has behaved over the last couple of years and how quickly it's evolving, I think there's just sort of this thought process of how do we sort of capture that in this vaccine that's made and deployed so that we don't have to go through this process of updating and redeploying these vaccines so frequently and sort of losing some of that potential immunity that we could afford to the public. There's sort of this other school of thought, though, that folks think that these new Omicron boosters might not, in fact, offer a dramatic difference in protection from the vaccines that are currently available. So worst case scenario, it sounds like folks think that this will be on par with what we have. Anything above and beyond that, I think, would be a bonus and what we would hope to see. But I think that worst case scenario there is still pretty good. As I touched on a little bit, right, the caution here that we're sort of worried about and waiting on is that we don't want to wait so long for these to be deployed that there's a new dominant strain, right? Because then we're going to end up right back where we are right now, where our available vaccines don't really match the virus that's currently circulating. So I think it is good that they've sort of moved this timeline up some. They're going to get this out ASAP, obviously subject to change, but what we're hearing at this point is September. One of the other things that's sort of up and coming and is really, in my opinion, flown under the radar are these nasal vaccines. And so these are vaccines that, again, could create these antibodies, but do so in the mucosal lining of our nose and other points of entry for the virus. So this would help both in the prevention of transmission as well as infection. There are currently actually 12 nasal vaccines that are in clinical trials, 4 of which are in phase 3. This does not seem to be something that the news is covering much, so I just wanted to mention it here just to let you know that this is kind of on the horizon. We've not heard much, if anything, about a plan for manufacturing or distribution or regulatory review like we had for our first vaccines. But again, just something to kind of keep an eye on, be aware of, and we'll see kind of what the data shows once they make it through those clinical trials. As I was putting this presentation together, I got a fantastic question from somebody who said, if I'm eligible for a second booster right now, should I get it or should I wait until these new Omicron boosters come out in the fall? I really don't have a great answer, but I'll tell you what we do know at this point. So the CDC is continuing to recommend that everyone should get their first booster once they complete their primary series. And then that second booster would apply to people over 50 or those who are over 12 with that moderate to severe immune compromise. So the guidance and eligibility criteria from the CDC on this has not changed. I think due to the increase in cases we're seeing with BA.5, there's been a lot of discussion about the potential to approve that second booster dose for all adults under 50. But as you can see from these recommendations, that has not changed. That hasn't happened yet. And now we know that that is not, in fact, the plan, and they are not moving forward with that. So in the last week of July, the FDA announced that they are not planning to authorize that second booster dose of the vaccine that is currently available for healthy adults under 50. So just to recap, because we're waiting for the new vaccine to come out this fall, CDC, FDA, they're not going to recommend healthy adults to get their second booster right now. So they're going to wait. Why are they going to wait? Well, we know that this vaccine that's currently available is not like super effective against BA.5 or that Omicron family in general. We know that the updated vaccine that's coming out this fall will have sort of that added protection against Omicron. And I think the last piece here that's really important in my mind is just this confusion, right? So the government is thinking, well, if we launch this vaccine and we have this big push now, and then another vaccine rolls out next month, like people are just going to be confused, not really sure what to do. So if we just wait until that new booster's out, we give that recommendation and do the push at that time, we would rather just sort of do that messaging once, have everybody get vaccinated with a vaccine, again, that will be more effective than the one we have right now. I think the caveat here is, right, that for high-risk individuals, people with chronic conditions, those that live in congregate care settings, this may be a different story. So what do you do if you're eligible for your second booster? You're 50 plus, you're immune compromised, and the answer here, as it's always been, is it's really up to you, right? So I mean, we know that the longer you wait and your immunity wanes, you're going to be at higher risk to develop COVID. But on the flip side, right, if you get it sooner, what happens then when the new one comes out next month? Can you get both? And we don't really know the answers to any of that, which I feel like I'm just a broken record saying, we don't know, we don't have answers to this, we don't know. But we just don't have all the information we need at this point. So the scientific community on this seems fairly split. There are folks that do indicate that there is benefit to getting that booster now. The data we reviewed earlier does support that with lower risk of hospitalization and severe illness. But then on the flip side, we do have others who think maybe getting 2 boosters in such short succession isn't great. But again, deferring could put you at increased risk of COVID. So it really just comes down to what you think is best, both for you, for your residents, what they think is best for themselves. I think, given that the individuals in your facility are medically fragile, high risk, we have this congregate living arrangement, this is certainly a population that we are concerned about and that we really want to protect. And, again, at this point, we don't have evidence to suggest that if you get a booster right now with our current formulation, that would preclude you from getting another Omicron booster in September when the new formulation comes out. So unfortunately, not a great answer, but I would just, encourage you to share this information, to think through this. Hopefully this provides sort of a good framework for you to have some of these conversations, both with your staff and residents as well. Mid-September, whatever that means, it may be a month from now-ish is when we're anticipating these to come out. Could be earlier, could be later, we really don't know. So I think, as with most of this, it's how do you feel? What is your risk level? What is your comfort weighting? Perhaps you've just had COVID and you're still sort of on the recovery phase, and sort of weighing how those different factors, kind of play into your unique situation, I think will be important as you move forward in trying to make that decision. So as always, we're here every week and we're happy to answer any questions that you have, either related to this or anything else. But would just encourage you to sort of think through this, digest this information, and share it with those who you think might benefit from it. And with that, I'm going to take a pause. I know that was sort of a whirlwind on BA.5. Hopefully you've learned something. And Kim and Jill, I will sort of turn the floor over to you and just open it up for questions and discussion at this point.
Yeah, thank you for your presentation, Kelsey. I actually learned a lot from your presentation. It was very well done. I'm curious, our audience, have you had any indication from your pharmacy? Have they talked about the new vaccine and whether or not, like, how quickly it will be available? Or, I mean, has the discussions even taken place yet? Okay, yeah, no information yet, Tracy. Yep, thank you for that. Nope, okay. Have your residents, have most of your residents received their second booster doses, especially since, most of them, of course, are over 50 or immunocompromised? Okay. About 75% of the residents. Thank you, Kelly. Okay. I see Rita commented that families are starting to ask about it. Yeah, maybe you could use some of this information today to, I don't know, give them a little sneak preview of what's happening. Yep.
Yeah, and I think that's a good point, Kim. And, as I mentioned in my remarks, I feel like a lot of this is just, we don't really know. Like, we have the information we have. Obviously, there's still so much that we need to learn and we're waiting to hear about. So I think, if you can share what you have, in my opinion, that's always the best way to just sort of open that conversation and let them know you're monitoring it, you're working on it, you'll let them know what you have as you have it. But, same for us to share with you, we just don't have all the facts yet. So hopefully, though, this was helpful. And as Kim said, if you can share the slide deck with them or want to share bits of it, would encourage you to do so.
So Kelsey and Kim, I have a question for the group on the call. I guess I'm curious to know from your perspective, and if you think about pre-pandemic, and I know that's really hard to think back what it was like before the pandemic. But I want you to think about your infection prevention practices that you had in place at that time. How often you reviewed your protocol, who did you reach out to? Did you sort of have a lifeline to your county health department, your state, to find out sort of protocols to follow? And now fast forward to where we are today, and think about what things internally for your organization have changed as a result of this pandemic in terms of your infection prevention practice.
Rita commented on more proactive than reactive. Rita, it's funny you just put that comment there, and Kelsey, you might be able to help me out. Remember this conversation earlier today. Kelsey and I were on a HAI call, and the CDC is putting out some, it's in draft right now, but some guidelines in regards to MDRO infections and being proactive. Of course, I mean, we already know we should be proactive, right? But we're actually, though, there's a whole team regarding making proactive recommendations of the plan, the action, the follow through, implementation, and everything. So I think we're going to be seeing much more to come on being proactive with infections in general.
Yeah, and Kim, it looks like Tracy added much more awareness, more diligent tracking and trending, more emphasis on staff illness. And so I think, this sort of speaks to sort of changing your organizational culture. And that really sort of, I think, sets the stage, as Kim mentioned, sort of moving forward. When you think about your infection prevention practice, that I would also encourage you to think about how often you're reviewing your protocols. I know I spoke to a nursing home yesterday who said sort of has a lifeline right to their public health department. So when they have an outbreak, they're on the phone and they're really sort of looking to them and their state for guidance in terms of sort of the protocols to follow. So I think that's just a reminder, sort of our protocols that we put in place, even if it isn't quite with sort of that, we have an outbreak, but I want you to think about the protocols that you have in place outside of even your infection prevention protocols, and think about how often you're reviewing those, how often you're looking at the evidence, and really to see if the evidence has changed and do you need to update that. And again, that goes back to sort of changing your organizational culture. So I want to compliment the homes that are actually being proactive. Again, that is a shift that we're seeing, and it may have taken, changing your culture doesn't happen overnight. So I think these are positives to be thinking about within your organization that sort of keeps you, your staff, and the residents healthy.
What other questions?
I am curious if there's anybody on the line that has any sort of treatment anecdotes to share. I know I kind of breezed through some of the current treatment options that are available. So just wondering if folks have any tidbits to share about what they've seen in their own facilities as they've treated residents who might be COVID positive. Just curious sort of what your firsthand experience has been. Oh, good. I see a comment from Jamie. They treated a few residents with Paxlovid, did not see rebounds. They did well. That's awesome, Jamie. And I don't know, Jamie, if you're able to unmute and just talk a little bit about that, and just kind of like what the arrangement is, how you guys were able to get that. I know pharmacies, you can sort of get it in pharmacies now, but if you have any like partnership tips or kind of what this process looked like for you, I'd be interested in hearing. Oh, mic is not working. Okay, Jamie, thanks for trying. Maybe Rita, I'll pick on you because I see you have a very similar comment. You used it and it worked well for those who are eligible. Any tips, tricks, how the process went for you, things that you think would be relevant to share with the group?
No, not a whole lot. I mean, once we had residents test positive, we just reached out to their primary care provider. If they met, we had certain residents that didn't qualify because of kidney functions. We did have one that was on Paxlovid that passed away. We had one completely unvaccinated per their choice. Tried Paxlovid, obviously it didn't work. So that individual also passed away. But for the most part, it worked. It seemed to work well. And we had a lot of folks who tested positive that really didn't even show much signs of symptoms.
Okay, yeah, and that would sort of follow with what we're seeing with more of this like mild, potentially asymptomatic disease, which obviously is an issue for transmission purposes. And so Rita, were you just able to get it like through your pharmacy, or how did that work?
Yes, we just got it right through our pharmacy.
Okay. Yeah, I just see Jamie's comment. They, at the time, they could only get it at Meyer, so they had a staff member go pick it up. Resident was very confused while on it. Interesting. Okay, thank you both for sharing your experiences. That's helpful.
I have a question in regards to your relationship with your hospitals. So for those of you that take your short-term care residents, what kind of a relationship, if any, do you have with your hospitals regarding your vaccination efforts? Do they come to you already vaccinated? Do you have these conversations with those acute care people coming, from the hospital to you first, so that they're already vaccinated, they don't have to, go into isolation or what have you, whatever the case may be? Has that been effective, and is that something you're doing? Okay, so Jamie's, where you're getting your short-term care people, they do not vaccinate. Huh. You have to arrange vaccination you have to arrange vaccination once they arrive. Admissions are not coming vaccinated. I have heard from our medical directors that this is financially related. The hospitals have not been pushing this. And that was from Tracy. And Rita says our admissions all come vaccinated. We do not have staff to do quarantine anymore, and that we have to for positives. Yeah, a little bit of both then, huh? I had worked with a few nursing homes that have had very positive relationships with their hospitals, hospital liaisons. So they're in there trying to get people vaccinated before they get to you. Jamie says they get their vaccine from Omnicare. And I've been offering the vaccine to hospital staff. Oh my gosh, you're attached to it. Okay. Christina, admissions from the local hospitals are giving boosters and encouraging vaccinations prior to admission to our facility. And Mitchell says we have the same problem. We get a lot of pushback about pre-discharge vaccinations. Pushback, interesting. Huh.
It's very interesting just to see how different everybody's experience has been with this.
Yes, absolutely. Yeah, because it would be nice if we all played on the same team, right? You know, isn't working together to get everyone vaccinated be easier for everyone. Wow.
Absolutely. Awesome. Well, this has been a really great discussion today. I know we just have a few minutes left. I just wanted to take a moment to just kind of share a quick update. So we received some feedback that our sessions aren't always publicized. So what we're going to start doing is at the end of each session, we're going to share with you a handful of upcoming sessions. So, you know, week after week, kind of where we're going, what we're going to talk about. That way, if there's other people you want to engage, you can do so in advance and have them join us. We are really excited. Next week, we'll have Dr. Buffy back for her 4th session. And then starting the following week, we're actually going to kick off a 3-week immunization series and have some really good presentations and speakers lined up for the last 2 sessions of August and that first one in September as well. So just kind of wanted to put a plug out for this. It will be in your PDF slide handout as well. So you can, you know, you have a hard copy of it. But hopefully this is helpful just for your own planning purposes, so you can see kind of what's on deck, what things, you know, are kind of up and coming, so you can prioritize accordingly, and again, sort of invite others who this might be applicable for. I do see just one other comment here in chat from Jennifer. We order whatever vaccine needs we have each week on Monday and get them delivered on Wednesday. We are seeing hospitals are not pushing vaccines and boosters as hard as long-term care because they don't have to. Yeah, that's certainly a challenge there.
Boy, do I see a future topic coming up here one way or another with this. My head's spinning, Kelsey, or figure something out here, right?
Absolutely.
Yes.
Certainly looks like there's a need. So thank you all for your feedback on this. This is really helpful. And as Kim said, maybe we can pull something together on this nursing home hospital dynamic and figure out how we can sort of align and collaborate more effectively together on sort of vaccines and boosters here. So. All right, well, with that, have a great afternoon. Thank you all for joining, and we will see you next week.